to welcome you all to our July 2026 edition of Disparities Dialogue. I'm delighted to say that this month we're going to be focusing on stroke rehab recovery. I'll introduce you to our two experts for today. They are none other than Dr. Nneka Ifejika, who is at Ochsner Health, and Dr. Kent Simmons, who is at the University of Toronto. Welcome, Kent. Welcome, Nneka.
Thank you.
Happy to be here.
And so, as we usually do, we'll start off by showing you the articles we plan to cover today with our experts. The very first one takes a look at healthcare disparities in stroke rehabilitation and was published in the journal Phys Med Rehab Clinical North America in 2024. And as you can see, Dr. Simmons was an author on that paper. The second paper we'll take a look at are ethnic differences in post-acute rehab. And this was published in ARC Phys Med Rehab in 2025. Our third paper is a huge policy statement led by no other than Dr. Ifejika herself. So we're privileged to have her. She was the chair of the writing panel. And so we'll go into this particular policy statement, which was issued by the American Heart, American Stroke Association. It was published in Stroke in 2025. Our fourth paper looks at the influence of socioeconomic status on functional outcomes after stroke. It's a systematic review and meta-analysis, published in JAHA, my journal actually, in 2024. The next paper takes a look at the association between social networks and functional recovery after stroke, and was published in the International Journal of Stroke in 2025. Our sixth and last paper looks at sex differences in prognostic markers, exploring outcome variability after thrombectomy in large vessel occlusion stroke. And this was published in J Clinical Medicine in 2025. So we have 6 terrific articles, contemporary, covering a whole range of things that pertain to stroke rehab. And again, we're delighted to have our experts help us walk through the importance and the key aspects of these particular papers. So the first one, as we mentioned, is a paper on which Dr. Ifejika was the senior author and also included Dr. Simmons, and looked at the issue of healthcare disparities in stroke rehab. And so I'm going to hand it over to Dr. Ifejika Nneka to kindly walk us through this one. Thank you.
Sure. I'm so happy and honored to be here to discuss some of the work that we've done in our lab. Kent and I are a member of the Stroke Outcomes and Continuum of Care Research Lab that I founded about 15 years ago when I was moving from UT Houston to UT Southwestern. So it's called the Soccer Lab, and I am the soccer mom. And this is essentially one of our papers that we've written that kind of looks at the importance of analyzing things longitudinally when it comes to access to care and stroke rehabilitation. The whole purpose of our lab is to look at the importance of stroke rehabilitation, but not at one specific time point. Stroke rehabilitation occurs throughout the continuum. Pre-hospital choices that you make affect long-term outcomes with stroke care. So we wanted to look at things in terms of education, lifestyle, access to care, which determine the extent of functional recovery. We want to look at disparities in stroke rehabilitation that are traditional and non-traditional. Things like race, ethnicity, and sex are traditional. But what about health literacy? And what about the need for specifically health literacy in terms of access to translation services, things of that nature? And so we did a literature review looking at the body of stroke disparity literature from 2008 to 2022. And we cross-referenced PubMed, Ovid, ResearchGate, Google Scholar, looked into gray literature as well. We found about 527 articles, and we narrowed down the search to a total of 345 original articles to calculate percentages of articles published on stroke type and disparity category. And the findings are on the next slide. I want to show them to you. So you can see here the breadth and depth of what we did, and primarily the article types were related to race, ethnicity, but then we found articles based on insurance status, which is Medicare, Medicaid, lack of insurance, commercial insurance, socioeconomic status, age, sex, and other. Other included language barriers, medical communication, stroke literacy, and immigrant status. And the 5 areas that we wanted to focus on are below. So disparities in stroke-related risk factors, hypertension, diabetes, hyperlipidemia, Poorly controlled risk factors actually lead to increased stroke severity, and it affects outcomes, well, ability to participate in therapies. Disparities in the acute stroke setting, stroke type, treatment, and functional status. And then the most common one was, of course, disparities in rehabilitative stroke care, subacute versus acute rehabilitation, community-based rehab care, and functional outcomes. Language barriers, and what some of the studies have found is if you don't have a Spanish language translator, you need a language translator for some other language other than Spanish, you're not going to get access to care. So I'll give you an example. My father speaks Igbo as his first language. If my father had left MCA stroke and they had to use the language translation services, the probability of him getting effective therapies, physical therapy, occupational therapy, speech therapy, considerably decreases if he goes back to his primary language of Igbo. That's something that we're not really discussing in literature, but it's really important because the US is a melting pot, as is the majority of countries in this world. And so it's important to make sure access to care, and specifically related to language barriers, is exceedingly important and needed. The last was disparities of functional outcomes for survivors of stroke. So you've made it through rehab, you've made it through long-term acute care. Are you still getting access to care after that? What does it look like for you over the lifespan? What does it look like for you in 5 years, in 10 years? What about your post-stroke complications? Are those being analyzed and evaluated? So these are the 5 categories we looked at specifically in regards to disparity in folk rehabilitation. And then what did we find? I think we have to go back to my previous slide or forward to the next slide to look at the results. There we go. So although disparities extended to the rehab spectrum, which was the area of this article, there were no identified intervention research articles to address these inequities for stroke rehabilitation. So we found all the problems, lots of problems, but not a lot of solutions. So, conclusions were stroke-related disparities are present along the continuum of care, from pre-hospital to acute care to post-acute rehabilitation and beyond, starting with modifiable and non-modifiable health determinants, acute stroke treatment, access to rehab services, and functional outcomes. This has appropriately resulted in increased research needs to identify disparities along the continuum of care that can be addressed with targeted interventions. So the implications were, we didn't find any solutions. We found lots of reasons, but we didn't find any interventions to address these. So it's a field with critical needs. Rehab providers provide care to stroke survivors across the continuum. So from acute care and beyond, positioning them to address this call to research and to continue to improve stroke-related outcomes through purposeful care equity. Rehab providers also care for these patients chronically. So throughout the lifespan, people don't leave our clinics. They stay with us through the rest of their lives. And at times for the duration of the remainder of their lives, which provides a unique opportunity to contribute to important data longitudinally in long-term functional outcomes and disparities that exist across different time points. So rehab is the key.
Oh, thank you so much, Nneka. A very important study, obviously. And on one hand, the bad news is that there's a lot of need, but the good news, a lot of opportunity. And so that's fantastic. And so one question I had for you is that stroke recovery seems like a highly variable process. How do we build effective infrastructure for prospective stroke rehab research?
It's really going to be important to have data infrastructure from the acute care to post-acute to outpatient therapies. And we don't really see a lot of longitudinal data infrastructure. So if you look at specifically stroke research, acute stroke, there's a level of data there. Get with the guideline stroke is a good example, but we have the American Heart Association. But if you look at it, when it comes to functional recovery, there's a huge gap. We don't have built in what the functional scores are, separate from modified Rankin scale. Are people able to walk? Are they able to talk? Do they need assistance? Where are the caregivers? Do they have caregiver assistance? Is it formal or informal? We don't have that level of information longitudinally. So the first thing we'll need to be is an important data infrastructure. Second thing we'll need to be buy-in from health systems. If you're going to build this data, you have to identify it and then collect it in discrete fields. So there's a lot of free text of all this data. But what are you going to do with free text? Who's cleaning the data? Who's going to be able to pull the data effectively? How is it going to make sense? So you need to be able to find health system buy-in across the country and have discrete fields that make sense. And the third thing is research funding. Who is going to fund this research? Rehabilitation traditionally has been woefully underfunded. It was a subsect underneath the NICHD. So the Rehab Institute is called the NCMRR underneath the NICHD. It's not like NINDS. Everyone knows what the S is. But what is the rehab? it's nothing on that level of funding. So there's a desperate need for additional funding to really help bridge the gap when it comes to bringing research on rehabilitation up to the forefront.
No, thank you for making that point. And I hope that people who get to watch this might be informed and educated, especially policymakers, so that we can have more avenues to be able to fund stroke rehabilitation research. One other question I have for you, if I may, Nneka, is that what does the stroke rehab research team look like? So it's one thing to talk about funding, but what does that team that you put together look like? Who leads the effort? Who are the key stakeholders?
It's a great question. And you need to have a PI who has an understanding of the whole breadth and depth of stroke, which is not an easy thing. So I'll give an example. I lead our lab, but I'm a PM&R doctor who did a vascular neurology research fellowship. So I know how to speak rehab language. I know how to speak stroke language. I know how to speak with all the therapists. I know how to speak with all the nurses. So you want to have somebody who's essentially published in all those areas and has a true interest in what the importance of all those specialists is and how we can work together collaboratively. And you also want to have an understanding of the language that they all speak and what it means in terms of outcomes. So what I find is that when I go to ISC, I speak all aspects, all thrombectomy, all TICI scores. Then I go to a rehab conference, I speak all FIM, I speak all when it comes to functional outcomes. There's got to be somebody who's almost like the Rosetta Stone of research, who's able to cross-reference across these groups to be able to kind of carve a path through, because that's the best way to longitudinally assess outcomes, is somebody who understands what everyone's contributing and is able to bring it to effect.
Yeah, that made me feel very inadequate, Nneka, but that's okay. No, but thank you. No, that makes a lot of sense, and I think we need more of that phenotype where people are able to understand both languages, because that's how you're able to address key questions that cross both particular disciplines. I want to invite Kent, if you have any comments or questions. You were an author on this paper. Any other perspectives that you have on this you want to share?
Yeah, no, I think that was a fantastic overview, Nneka. And no, I kind of agree with you in terms of stroke rehab itself is dramatically underfunded. And I think really the important piece is to kind of bridge an understanding from our colleagues in acute care. And, one of the pieces I'll kind of give with residents sometimes is people seem to understand rehab when it's something that they go through themselves or a close family member. And we'll talk about, we'll get to this later, but outcomes that we commonly use, like modified Rankin scores. But some of the challenges are, and I've asked, acute care neurology colleagues is, how does a patient transfer? And they'll pause and they say, that does sound important. And I think it's important that we bring these real world limitations to bear, and otherwise we're at risk of missing out on some of these outcomes that matter to patients. But if we're not capturing them, we're not measuring them, it's difficult. And I think it also kind of outlined the need to move and kind of advance the field from looking for differences to kind of moving into testing and trying to bring real world differences and what actually works to reduce these disparities with time.
Yeah, very well said. Very well said. Our next paper, entitled Ethnic Differences in Post-Acute Stroke Rehabilitation, published by the BASIC Group, who are in Michigan, and was published in 2025. Nneka is going to kindly walk us through this one.
Sure. So I have a very close relationship with the BASIC Group. Believe it or not, BASIC started in Houston. So Louis Morgenstern was junior faculty as a part of UT Houston Stroke Program, worked there, and took his large grant back with him to Michigan, where he is from. And it was funded for about 30 years. So BASIC stands for the Brain Attack Surveillance and Corpus Christi Project. It began funding in the mid-1990s. And I think it was recently affected by the changes in funding, but they received the Javits Award, which is almost like a super R01, which is a very high prestigious award from the NINDS, to give you an idea of how important this work Louis and Linda Elizabeth have done over the past nearly 30 years. They enrolled over 15,000 participants in Nueces County, Texas, and the surrounding area, which is Corpus Christi. It's a bi-ethnic community. 63% of the population identifies as Mexican American, and 30% identifies as non-Hispanic white. And it's also minimum influx and efflux of residents, basically meaning people stay there. Patients can be followed longitudinally from stroke occurrence to beyond hospital discharge. The county has 7 hospitals and only 1 CSC. So everybody gets care in this county. So it's a wonderful opportunity to look at longitudinal data and stroke outcomes, which this group did in the study. And so the methods of this paper, stroke patients or their proxies were contacted every 2 weeks for 90 days after stroke to identify their rehab provider. And they determined whether the person went to inpatient rehab facility after their stroke, skilled nursing facility, home health agency, or outpatient rehabilitation. Binomial regression was used to model association of ethnicity, Mexican American versus non-Hispanic white, with IRF as first rehab provider, which is pretty much what you want. If you are able to tolerate 3 hours of therapy a day, you have appropriate insurance, you're able to have a caregiver, you want to go to IRF. And that's what they chose as the primary outcome. Sequential modeling and propensity score adjustment was used to investigate demographic and clinical variables impacting ethnic disparities. And the findings are on the next slide. So you can see here, there were a total of 1,453 patients. Any rehab was 974, and that includes, again, SNFs, IRF, home health agency, or outpatient, as delineated here. And the study found that non-Hispanic whites had higher IRF usage as the first provider compared to Mexican American patients. And you can see the risk difference there of 7.4%. This difference remained after adjustment for patient and clinical factors, which means insurance. Look, and that's very important. So that means if you had Medicare insurance, both groups, you still had higher IRF usage if you were non-Hispanic white compared to Mexican American. And clinical factors, but was attenuated by 74.6% after further adjustment for socioeconomic factors. So it was really important to look at specifically how this affects our patients moving forward. And we can go back to the results slide. So it was really important to show that the sample size, even though it was a longitudinal study, prospective, the best it could be was 1,400 patients, which is some of the pitfalls of rehab research. It's very hard to get large sample sizes to conduct subgroup analyses. It also did not include a robust analysis of transitions between rehab providers in this study. So for example, if you had a provider who was in the IRF and the person then went to SNF, is it the same healthcare provider? Is it a different team? Are they having the same access to care? Same thing for therapists. So people are leaving one setting and moving to another. Do their care plans transfer? Is it the same level of rehab duration across levels of care? So the conclusions were lower percentage of Mexican American stroke patients went to IRF versus non-Hispanic white stroke patients in the 90 days after stroke, which is pretty much when you really want to start revving up your post-acute rehabilitation plan, because that basically portends what you're going to get in the future. Socioeconomic status was the major driver of the difference. So the implications are IRF care is not the only driver of improved outcomes, but it provides opportunity for effective post-stroke follow-up. So if you can imagine, if your length of stay on acute care, they want to keep it down to less than 4 days now, I believe, for ischemic stroke. So that means if you're going to rehab, you're able to get all of your outpatient appointments set up, your primary care provider set up, your equipment set up, your caregiver gets educated. That's on top of the rehab care, you're getting 3 hours of therapy a day. So it provides this kind of this cocoon around you of support during the 1.5 to 2 weeks you're there. And that's also on top of continued rehabilitation services. So it's not so much about just inpatient rehab facility of care. It's about what that means overall. It's a comprehensive level of care that cannot be replicated at other environments.
No, thank you so much for that, Nneka. Another very important study provides some great insights, even with the limitations and everything. I was a little amused when you started off and you said that Lewis got funded in Houston and then took the grant with him as if he shouldn't have done that.
Listen, Jim Grada trained me. He tried to keep everybody there. So I have to say it. I adore Lewis, but he took the grant with him.
Absolutely. But to your broader point, a very, very important body of work over the last 3 decades, which has shed a lot of insights into these disparities. But the first question is, and I'm sure it's on the minds of many of our viewers and audience, is that how generalizable are these results? Because even if you look at just the Hispanic community, it's quite broad, right? So we're looking at Mexican Americans here. And then if you look at minority populations generally, so you're an expert. To what extent might this be generalizable beyond this particular study?
I think that this study is important in the setting that it's in. Generalizability is going to be difficult for some of the reasons that were the strengths of this study, right? There's minimal influx and efflux of people. It is a bi-ethnic primarily community. There's only one CSC and there's only 7 hospitals. In the majority of cities you go into, the number of CSCs can change on the same street. If you go to Houston and in the Texas Medical Center, there are 3 CSCs on one street separated by about 6 blocks. So in a place like Houston, no, this may not be generalizable at all. So it's really important to kind of look at that as this is a strength of this study, but generalizability, it would be a weakness.
Oh, this is a great point. And do you know if the investigators have studied the effect of high rehab duration SNF care?
Great question. And Ken's going to be looking at that in some of his research moving forward. They actually have not. It's a very difficult thing to study prospectively because you have to study the timing of minutes of physical therapy, occupational therapy, speech therapy. Then you have to also look at their functional level. So were they minimum assistance going to independent? Did they have equipment that they use? Did it require 2 people? So there has to be a way of calculating that. It's not just rehab duration, but the intensity of the intervention as well.
No, thank you, Nneka. And of course, you provided a great segue for me to invite Kent to provide more context to that particular question, if any.
Yeah, no, I think it's a great point, and I think it just comes down to some limitations that we have with measurement. So a lot of times, what most literature looks at, it's time intensity of rehabilitation, but that time intensity can be anything from mobility in bed, range of motion exercises, to more advanced, body support treadmill exercises. So the specific ingredients of what's actually occurring within these rehab contexts, a lot of times we don't know, and there's a lot of variation center to center, and so there's more work kind of there's evidence showing the importance of early high intensity activities, but there's a lot more work as well to kind of delve down into the specifics of that, of where we're actually driving these differences.
Thank you. All right. We'll go to our third article. This is Nneka's baby right here. And so this looks at, figuratively, this looks at an American Heart Association, American Stroke Association policy statement. And for those of us who've had the profound privilege of doing this is a really important level of discourse. Experts are invited, there's a gap identified, and when the AHA does this, they are really trying to inform policymaking at many, many levels. And so Nneka led this particular paper, was the chair of the panel, and was published in Stroke in 2025, so extremely contemporary. So Nneka, walk us through this wonderful work you did with your colleagues.
Thank you so much, Bruce. I was honored to chair this amazingly dynamic group of colleagues, and they've all been working for literally, there was almost a couple hundred years of expertise on this paper. So it truly was an honor. And some of the background is stroke is one of the most expensive medical conditions covered by Medicare. And there's about 10,000 people entering Medicare every day in this country. So it is a huge, huge volume of people. And the burden of stroke is really important. And so the economic burden of it is expected to rise over 5-fold between 2020 and 2050. To a total of $423 billion. And that's not including some of the costs that are not measured, such as informal caregiving, which is not numerically defined. Despite the growing cost burden of stroke, access to stroke rehabilitation care is not often determined by clinical need. There are large gaps based on race, as we've discussed, geography, urban versus rural, insurance type, and socioeconomic status. Some patients, including those in rural areas, face steep barriers to accessing post-acute rehabilitation services, widening disability gap compared to stroke survivors in urban areas. So some of the key measures we wanted to focus on with this policy statement were, the first one was advancing research. I cannot say that enough. We need more research that reflects real-world recovery challenges, as we've discussed already. Developing a national data infrastructure. Once again, if we have the data, we can affect change, we can affect policy. Whenever you go to CMS to advocate, whenever you go to Capitol Hill, if there's an OIG report that's put out, the first question they'll ask you is, Dr. Ifejika, do you have data? Do you have data to show us that we're wrong? Well, that's why it's important to develop a national data infrastructure around stroke rehab and recovery. Evaluate and compare rehab models. So is IRF needed for everybody? Is there a high intensity versus low intensity SNF? What's happening in outpatient therapy? Is home health what it needs to be? We need to be able to compare and contrast models for clinical effectiveness and cost efficiency. Study the impact of systemic factors such as insurance coverage, geography, health systems, and payment models on rehab quality and patient recovery. And then enhance care coordination and discharge planning by expanding staff training and addressing the unique needs of patients and their caregivers from various social and economic backgrounds. So the statement highlights major gaps in the U.S. rehab complete construct and identified needed improvements in public policies and performance measures to incentivize optimal patient care. We got to set evidence-based policies to improve this for post-acute care after stroke, as well as acute care stroke, because some patients don't get post-acute care. If you are uninsured, you sometimes get sent home, depending on what hospital you go to, with a home exercise program. So we need to make sure there's an understanding of not just post-acute care, but acute care and bridging the gap when it comes to rehabilitation. Urgent need to conduct studies including using contemporary representative population-based samples. Again, data is going to be the key to helping solve some of these problems. Can we go to the next slide?
Yes, and I know you have some other slides to drive home the point for us.
I did. So this is a stroke team 15 years ago. It's my stroke team. So I was in Houston and we are standing on the stroke unit. But it's not just about the team, it's about the composition of the team. So we have vascular neurologists, we have neurocritical care, we have PT, OT, and speech. We have acute care nurses and rehab nurses. We have vascular neurology fellows, all of whom are part of the same team. There is no differentiation. We're all standing in a stroke unit. This is our new stroke unit, by the way. We were fancy with these rooms. But at the time, we're taking care of only about 1,000 patients a year. This same team takes care of about 3,500 patients a year at Memorial Hermann TMC. But the thing that we had going for us is that we had data infrastructure from acute care through post-acute rehabilitation. All the providers were a part of the same care team. We met every week around a table and discuss what was happening with all of our studies throughout the continuum of care. We had buy-in from the healthcare system. This is a picture I took of a plaque on the wall of the stroke unit. The healthcare system had to sponsor this. I didn't just take this as a screenshot. They created this as something that's a deliverable through our healthcare system, that you would get equitable access to acute care and rehabilitation by the same team. And that's a really important construct that we came up with 15 years ago. And that's how I was able to do the research that I'm doing, because I was empowered to do so by my mentor, my healthcare team, as well as the people around me who believed in the importance of post-stroke rehabilitation.
No, and it's very, very exemplary. I mean, Jim Grotta is just a leader and somebody we all owe a lot to in terms of driving stroke forward and everything. And so thank you so much for emphasizing this as an exemplary model. If you don't mind, I'll just say this, that even with seeing over 1,000 patients a year and 15 years later, you and Jim don't look a day older. So that's fantastic. So
trying to keep it together, man.
All right.
And then I wanted to show some information about the cost of care for Medicare beneficiaries. The best proxy that the CDC has is specifically heart disease, which includes stroke in this instance. You can see the stroke belt is still the stroke belt. It's just what it is. And you can see here the 2020 post-acute care cost and the incremental cost of care diagnosed with heart disease. So it's all very expensive, but notice the heat map is throughout the middle of the country, specifically focusing on Texas, Oklahoma, Louisiana, Alabama. And then if we go to the next slide, I want to show you something that's going to be a bit of an inverse and concerning. So you can see cardiac rehab eligibility rates. Makes sense. It heat maps right onto what we saw before. But then you look at the next one. Look at the rehab participation rates. It's mostly in the Midwest, the upper Midwest. So you can see how the need is in Texas, Oklahoma, Louisiana, Alabama. But where's the access for rehabilitation? Look at the dearth of it throughout those areas. So again, this is something that we need to address. That's why we wrote this policy statement. In these areas where rehabilitation is desperately needed, the access is limited.
No, thank you so much for that. And always they say a picture is worth 1,000 words. This really drives home that point very, very well. Again, thank you for guiding us with that statement that you led on, Nneka. One question I have for you is, what is the effect of Medicare prior authorization on access to stroke rehab?
Oh, I've written some shady things in that policy statement, so I hope everybody reads it. But what's happening now that we've noticed that there are three main insurers that are listed in the policy statement that are using specifically tactics to deny access to care. They're using AI. They're teaching people who are doing the prior authorization on what tactics they need to use to deny people. And it's a part of their essentially the way they're building money. So a congressional report came out that basically assimilated over a couple 100,000 pages of information that they requested in Congress. And they basically showed, the report showed that this is not only happening, it's systematically occurring where Medicare beneficiaries are specifically being denied the care that they paid for by going into the Medicare system for decades. So I have that in the paper. There's three primary players that are doing this, and prior authorization is something that we really need to address as healthcare providers. So if you are a primary care provider, a vascular neurologist, a rehab physician, and you notice that your patients are getting denied access to care, take a look at that insurance type, because there may be a systematic process disenfranchising them from getting the help that they need.
Absolutely. And you touched on this already a little bit, but what does enhanced care coordination look like, and how can it be best implemented in healthcare systems?
It's a good question. So it's really important to include rehabilitation early. So at UT Southwestern, Dr. Simmons will tell you, stroke rehab was checked off automatically as part of the order set. You had to uncheck me. So it means for every patient who was admitted to the hospital, the rehab consult was done on day zero. So you're still in angio suite. And sometimes I come down to angio suite and meet your family and meet the caregivers and have conversations. So there is no denying that this is an important part of what is going to be required for you to get back to where you need to be. We had huddle rounds every day where human R, vascular neurology, neurocritical care, all of the therapists, the nurses came together and discussed your case. And we have virtual rounding tools built into the EMR. So we could see when your MRI populated, when your echo was done, when you were mobilized by therapy, your whole medications, we could reconcile them with your new medications, whether we found your caregiver, whether the caregiver likes you. That's important too, because if your caregiver has no interest in caring for you, the probability of you going for inpatient rehab facility care decreases. This is all a part of what we did specifically as a part of enhanced post-stroke care. And then when you went to rehab, we had to figure out a way for the therapists and the rehab professionals to speak to the vascular neurologists. We created a crosswalk between modified Rankin score and the GG codes used on rehab so that everyone could speak the same language. That's enhanced post-acute care. That's enhanced acute care. And that way the patient knows and has an understanding that we are vested from the second you hit our hospital throughout the care continuum.
That's fantastic. And again, exemplary. Just wonderful to hear that kind of proactive, engaged approach. I'll have to use that phrase. You have to uncheck me. I have to have to incorporate that into my lingo. Kent, what are your thoughts?
I guess a couple of thoughts. One, I can attest to that as a resident. I remember getting a couple of calls from the ED about a stroke consult. And I'm like, what does the emergency department want a rehab guy for an acute stroke? But then after the fact, figuring it out, no, I think it makes sense. I think another piece is, so I did, just for background, I did my training under Dr. Ifejika at UT Southwestern, then recently moved up to Canada. And this cardiac rehab map is fascinating because in Toronto, the patients that I see, almost all of them will get referred to cardiac rehab, but did not see a lot of that practicing in some of the hospitals in Texas as well. And then I think the final point that you kind of alluded to in that policy statement is, insurance and cost of care. They're very real things, and it's a bit of a cat and mouse game in terms of denials and having the evidence for it. I think it's really important to consider the impact of sort of patient selection for these different settings. So only about, 20 nationally, about 25% of patients go to inpatient rehab. And so I think it's important that we look critically at which patients are going and trying to target the patients where we can actually demonstrate we're getting functional benefit for these patients. Otherwise, I think it's kind of a losing game if you don't have strong data to support your case for, to be honest, is expensive care. But from personal experience, we do see patients get better, and I think our ability to predict how patients do, it's pretty uncertain. A lot of heterogeneity in those recovery trajectories, and I think everyone sort of deserves a chance to demonstrate their ability to recover.
That's great. No, thank you for that. Thank you, Nneka. We are now going to hand it over to Kent to walk us through the first paper that he has applied his expertise to. And this is entitled Influence of Socioeconomic Status on Functional Outcomes After Stroke. It's a systematic review and meta-analysis published in the journal that I am privileged to lead, the JAHA, in 2024, and led by a colleague of mine as well. So, Kent, please teach us.
Okay. Yes, this was an interesting paper as you discussed by Nguyen et al. So it's sort of looking at the fact of SES. It's a broad, sort of ill-defined term that we all kind of have some conceptions of it. And it has been associated in literature with poor functional outcomes. And they kind of broke down what are the components of SES, and looking at these individually to see if there's any associations with how patients do. And so they kind of broke it down into income, occupation, education, and then social class as well. And so they wanted to, first of all, look at is there any association overall, and then to see which one of these indicators potentially had the strongest level of evidence for predicting functional outcomes. So they did a systematic review and meta-analysis using a search from inception to 2022, so a long study period from both Medline and M-Base. And they were looking at observational studies, so larger studies of over 100 patients. The outcomes that they were selecting were the common ones that we'll use. So modified Rankin is probably one of the most common in the stroke literature, and then also the Barthel Index. And then they had some difficulty in terms of how to operationalize these comparisons across studies. So they essentially went down to trying to compare the highest to the lowest groups when possible. And they were defining a poor functional outcome, so modified Rankin of less than 2 and a Barthel index of less than 60. And then they also had a risk of bias assessment done. And then just given the heterogeneity across countries, this was not specific to the US, they used a random effects model. They identified 19 studies, over 150,000 participants. So within these studies, they found education was the most common indicator of SES that they found associations with. 8 studies looked at income, occupation was 4, and then there was also health insurance, and then a neighborhood deprivation index. They found that across the board, education, so they were looking at the binary comparison, so essentially less than high school or greater than high school. So they did find a higher association with lower levels of education being associated with higher odds of having poor functional outcomes, about 66%. And then for occupation as well, so those that were either unemployed or doing more manual type work, compared to people that were fully employed or non-manual work, again, they found about a 62% higher odds of having poor functional outcomes for those. The neighborhood deprivation index as well. So not just who you are, what you do, what's your education level, but the environment in which you live and operate. That demonstrated independent association as well with poor functional outcomes. Income, about a 36% increased risk of odds, still crossing that statistical significance. Health insurance, we'll get to some of the limitations, but they didn't find a statistically significant association there, but it was trending towards significance with an adjusted odds ratio of 1.32. Some of the limitations of this, so they were looking at studies kind of across the board. I think the majority came from the US and China, but they had a number of other studies from South America, Asia, Europe as well, across the board. So to operationalize these broad constructs of SES, income, and especially health insurance across countries, pretty challenging to do. Um, and also how you parameterize these variables, right? I think a lot of studies would break down education or income into a variety of different ways. And so your ability to combine data to make meaningful associations is pretty challenging with this type of work. And there is limited or inconsistent adjustment for rehabilitation type care as well. So as Dr. Ifejika brilliantly sort of described, where you go after the stroke matters. It's not just the stroke and the environment in which you live. And so we weren't able to adjust for that, which we know can be a direct impact on how patients are doing after their stroke. And there was also limitations in their ability to do substratification by sort of stroke subtype, age, and sex. Just some of the challenges of combining the data. So in conclusion, I think they found a number of these constructs of SES were showing associations with first functional outcomes. So it's not just your health, it's the health, it's your socioeconomic background, and it's the environmental context and where you live, which is directly associated with how patients are doing after the stroke. And education itself, I think it was interesting that that was the most significant driver, especially over things that when we traditionally think about disparities research, sometimes we'll think about access to care and health insurance that might mediate that, but it was the education itself that was the strongest driver. And I think the implications are to read off the slide, to optimize stroke recovery. It's a more holistic understanding of not just a patient and their medical comorbidities, but who that patient is, and then a more contextual understanding of who that patient is, as well as their medical comorbidities and where they live. All of those will kind of interact for how they'll do after their stroke.
Thank you. And I know you have this summary slide you want to talk
Yeah,
about.
so this is kind of just summarizing what we're saying. So again, we're kind of seeing that education itself, across 11 studies was showing the strongest association with poor functional outcome. But across the board, these different constructs of SES in general were all showing higher associations with worse functional odds, with the exception of health insurance. But again, it's trending towards statistical significance, but just didn't quite make it.
Yeah, no, thank you, Ken. Again, a systematic review and meta-analysis, but has interesting implications for how we think about this issue. And so I wanted to start off, if I may, Kent, asking you about this issue of education. So one of my good friends and colleagues, Jide Williams, when he talks about stroke disparities, he says stroke disparities are really education disparities. That's how he sees it. He says that's the
Mhm.
background to it. And it's interesting that this study, education was the strongest predictor. It's important to point out here that in some ways they looked more at the quantity of the education, not necessarily the quality of the education, but wanted to get your own insights as an expert, a rehab expert, about why you think that education had a stronger association with poor functional outcomes compared to the other factors like income or health insurance, and what could be some of the implications of this?
Yeah, I think it kind of comes down to, when we think about these issues and disparities, we've really got to take a deeper look in terms of what it actually is. And again, not an over-reliance on just number of interactions, access to care. It's deeper than that. It's what occurs in that interaction. And I think this, with rehab in particular, we don't do a lot of direct treatment. More of it really is management. And the management requires education from the patient, from their family, from an understanding of these are the deficits that people are having. And this is the variety of techniques or medications, or therapy exercises that we recommend for continuing to work on functional recovery. And so I think that's really the piece, is that if it was a simple pill problem, then access might matter. But rehab is more to it. And that's where I think things like embedded within that, elements like health literacy, might sort of be some of the factors that's showing that association.
Absolutely. My other question is, do you think that our current healthcare system, and by current, usually we talk about the US, but I recognize, of course, you're currently in Canada, and of course, there are other healthcare systems, and we have members from around the world. But let's stick with the US, for instance. Is the current US healthcare system set up to address the socioeconomic inequities? And can it adapt to better identify and address them so we can improve outcomes after stroke?
I think there are challenges, particularly, like I said, it's a lot of people from the education itself of an overemphasis on, the pathophysiology of stroke. And I think, as a clinical epidemiologist, I'd like to advocate a little bit more for understanding functional outcomes. And as a physician, you need to know the biology, you need to know the pharmacology, but that's incomplete. And I think there is, from the training point of view, there needs to be more emphasis on looking at what are the factors, be them, it's sexy to say this is the pathophysiology and here's a brand new medication. It's not that exciting to say, hey, let's range that arm so we don't develop contracture. But really, that's probably one of the most effective things that we have to prevent contractures. And so I think the emphasis on outcomes, and I think the other sort of challenge is, as Dr. Fetchker's policy statement said, is, we need the evidence of showing where do these interventions actually work and where can there be cost savings. And I think really from a systems point of view, you have to take the practical focus that it's going to be a lot of times more in-depth economic analysis and demonstrating functional benefits before you'll get the funding to try to implement other pieces. And so just sort of the cross comparisons, and I haven't seen any specific data on this, but within the US, you can get patients that will have home care after a stroke. And there would be some patients that would have that. But within Canada, the government will fund these personal support workers. And so I've seen far more utilization of that within the Canadian context compared to the American. Again, I haven't looked specifically at outcome data, but I think these are some of the measures that systems can use to try to adapt for it. But it's not cheap. And in a world of, constraining budgets, I think it's really important that you are able to identify the benefits of these to have the argument to make the policy changes to enable it.
Yeah, no,
So we
well said.
can, but it's a tough road ahead.
Yeah, no, well said. And I want to broaden the conversation a little bit, and I want to invite Nneka to kindly weigh in along with you, Kent, if you have some thoughts about this. Typically, when we do these disparities dialogue articles, many times we have global papers that focus on the low to middle income countries. We don't really have a lot of that in this particular series for this month, but in the context of socioeconomic disparities, in the context of many of things that Nneka mentioned, the fact that Nneka has an Igbo-speaking father, and I've been privileged to do research in Africa a lot. When we look at the paucity of care, stroke care in Africa, whether it's acute care, whether it's inpatient care, rehab is the most dire in terms of need. There's a complete paucity. I mean, people don't have anything. It's non-existent
Mhm.
completely. So I just wanted to get your thoughts about that. I mean, we are speaking about high income countries, the US and Canada, and even then there are some differences in approach. But as both of you weigh in on this particular paper, I would love to get your sense of um, what you think about what's happening in low to middle income countries, and just take it where you will. Thank you.
Do you want to go first, Nneka, or you want me to take the first one?
Sure. I'm happy to go first. So, it's that my concerns regarding the lack of rehabilitation in low to middle income countries, particularly in Africa, cannot be overstated. Like there simply are not enough rehab providers. Like let's forget about rehab providers. There aren't enough therapists. There aren't enough rehab nurses specialization. There aren't enough physiatrists. There aren't enough, honestly, there's not enough vascular neurologists either. But there aren't enough rehab providers. And so the importance of education of the community, of caregivers, of nurses on rehabilitation paradigms, whether it be through telerehabilitation, whether it be through reaching out to health systems there and making sure that they have the educational ability to download information to utilize in not just the cities. I'm talking about in the towns, in the villages, creating a network of care provision through community is going to be really important to help bridge the gap. I'm thankful that family is important. You could talk to anybody from sub-Saharan Africa. There aren't a lot of nursing homes in sub-Saharan Africa. There isn't a lot of that. You take care of your family. You have an extra room in your house or two rooms in your house, and you take care of that person that's had this stroke. And so it'll be really important to make sure that the education and knowledge is passed to the communities, to the caregivers, because informal caregiving is going to evolve into informal rehabilitation. And I think it's going to be something that'll be the next step of helping, at least helping in some way to bridge some of these large gaps.
Thank you. Kent?
Yeah, no, I think that was well put, and I think part of the piece too, it's the same paradigm shift that we were kind of went through in more developed nations. Is that initially there was this big focus in terms of stroke mortality and our outcomes, and the language Dr. Fetchke you speaking is mortality and hospital readmissions, but rehab is more than that, right? And again, kind of alluding to my previous point, it's if it's you or you're a close family member, then you want to know more than that. And I think first is kind of recognition, and then second is also education within the healthcare systems to be able to do that. And there's a big piece of rehab itself that it can be family education. So that, again, people are aware in terms of some of the basic things of mobilization of patients. And really from rehab itself, you have, the physiologic and biological improvements in recovery that kind of occur for the first 30 to 90 days. But after that, a lot of it's really moving towards tertiary prevention and preventing the complications of these post-stroke deficits. And that's really where the education kind of comes in. So I know there's been some movement within the ISPMR and WHO when it comes to rehab. And so I think it's not my area of expertise, but I think there's some positive movements in that way. And just a personal story, as my last rotation in medical school, I went to Malawi, and I went to Michigan State for medical school, and there was a researcher there that really big in WHO, and she focused on malarial research and cerebral edema in patients. And, I think I asked her the question, what would you do if you could do it all again? And I was floored when she said, I would go into rehab. And because she was identifying the need and where the next steps were, as well as some of the changes that were occurring. So, I mean, that's just a little bit of a personal experience, but I'm hoping that wasn't unique. And I'm hoping that throughout the developed nations, there has been movement towards recognizing and beginning to implement these systems, but it's a long road ahead.
No, well said. I'll just spend a few more minutes, maybe a couple of more minutes, just talking about this. So, number one, of course, you're speaking about Gretchen Berbeck. Gretchen Berbeck was honored as one of our SEQUINS Hall of Famers
Hmm.
this year because of the groundbreaking work she's done in Africa. She's just a pioneer, and so many of us are just grateful for the work that she's done. The other thing, as Nneka said, is that the concern about the dearth of stroke rehab cannot be overstated. I think you stated that well, because it's such an issue. I know that my vascular neurologist colleagues will feel this is an anathema to say, but acute care is important, and we're trying to get more TPA and everything. But there's a much higher burden of hemorrhagic stroke. Unfortunately, the mortality is quite high. So really, prevention and rehab are the cornerstones of this. This is
Hmm.
really true. And I suspect that's why Gretchen on the ground said what she said to you, Ken, because it's extremely important. So I hope that more and more people are aware of this issue because it can be leveraged. We've tried to get funding to do some tele-rehab because of Nneka's point. There's a very high mobile phone penetration in Africa, even though, again, resources are not great. There's great mobile phone penetration. How can we better leverage that to get those those caregivers to do more rehab? But I preach too much. We have to move on. So, but thank you, thank you, thank you. Thank you. All right. So our next paper. Oh, I'm going backwards. I beg your pardon. Here we are. And so the next paper talks about the issue of association between social networks and functional recovery after stroke. It was published in the International Journal of Stroke in 2025. And Kent is going to kindly walk us through this one.
Yeah, so this was a perfect segue for your previous comment about connections. So some of the background on this, so social determinants of health, it can impact both outcomes. And so again, normally there's been an overfocus on death and rehospitalizations, but there's more of a movement towards getting a better understanding about quality of life types of metrics. And so the objective of the study was to examine associations. So they looked at a variety of pieces of social determinants of health and post-stroke function. So they used data. There was a previous existing NIH study, the Transitions of Care for Stroke Disparities study, which was conducted in 2018 and 2021. So this was all stroke, so both ischemic and hemorrhagic stroke. And so it was conducted in Florida across 12 comprehensive stroke centers. They excluded patients that were discharged to settings other than home, assisted living. I wasn't sure if that was skilled nursing or not, or inpatient rehabilitation. And then they looked at a variety of social determinants of health. And one of the key ones they looked at was the social network size. And so they were looking at small social networks of less than two people and comparing them to those that had larger social networks of greater than three. And they were looking at the change in the modified Rankin score from hospital discharge to 30 days compared to 90 days. And predominantly they were looking for some kind of decline in function. And they used logistic regression, and they did because they were looking at multiple potential exposures. They used the least absolute shrinkage and selection operator. for variable selection. The key findings for them is they did find that the smaller social networks, so less than two people, were associated with an increased risk of functional decline at 30 days. So odds ratio of 1.39, so interpreted as a 39% increase in the risk of odds of having a worse modified ranking score after 30 days compared to a discharge. And then that difference actually increased a little bit if you're looking at 90 days, where the adjusted odds ratio is 1.5. And then they also found that individuals that live with children or spouses were less likely to experience functional decline. Some of the limitations for these was the sample size. I've got on the slide. I think it was around 1,800 patients or so, and they were looking at multiple exposure variables potentially. And the primary outcome, they were using modified Rankin score, which is more of a sort of a general and global measure of post-stroke function and doesn't necessarily give us some of the more granular details of how patients are actually operating. And there's also risks of a ceiling effect. So at discharge, over half of the patients, 55%, had good MRS scores of 0 to 1. And so it's harder to demonstrate decline with that. And what they found was that social network sizes was the strongest predictor of functional decline at both 30 and 90 days. And the implications were these smaller social networks or social isolation, as it's been described in other places, is associated with experiencing functional decline after stroke, and that these social networks themselves can be considered a modifiable risk factor. So you can have formal and informal social networks. And so we can try to mitigate some of these differences from a healthcare system perspective with things like navigators, community health workers, personal support workers, things of that nature.
Absolutely. Absolutely. An important study, I think. Ken, clinically, how do you conceptualize the issue of the concept of stroke recovery, and what are the factors which impact recovery?
Yeah, so stroke recovery, I think it's hard. I think a lot of people might think of stroke recovery in terms of motor recovery and in terms of strength. Do they get stronger? But strength is not necessarily function. So function is, broadly, but your ability to do the things that you want to do. And so function itself can be impacted. So you can have the physiological changes of stroke recovery. So things that we think traditionally neuroplasticity, restoration of neural networks, right? That might kind of have some of these physiological improvements in strength or cognition, elements like that. But function itself, again, you can show that people can, with rehabilitation, can learn new strategies, can get assistive devices, to kind of make up for biological limitations. So, for instance, if someone, if we're looking at mobility, the goal is to get from one part of the room to another part of the room. And so if you've got weakness in your legs, maybe that's challenging, but maybe you can use a walker or maybe you can use a wheelchair. But the context in which people use that wheelchair also matters. So is it a flat surface? Are there stairs? If they've got weakness in the arms, do they have social support to help push them? And so when we're looking at these measures, I think it's important to differentiate between the physiological elements of improvement, which traditionally will learn. Most patients will improve for that first 3 months or so with functional decline. That might be maybe they're getting stronger, but they're actually getting worse in function because they don't have the assistance for bed mobility. So they're getting secondary effects of deconditioning because they're not able to mobilize out of bed. And so I think it's important to really conceptualize those differences when we're thinking about stroke recovery, and to conceptualize it a little bit deeper. So when we're in the acute care phase, what's the risk of this patient potentially getting worse after they go home? Even if from a stroke perspective, maybe they are going to get some neuroplasticity during that period of time.
No, that's super, and I love this because again, I learn as you were explaining things there. That's extremely important. May I now leave your rehab mind and tap into your epi mind and ask you about when reviewing these type of social epi-oriented studies, how do you interpret results that are broad but somewhat uncommon and ill-defined risk factors, such as this, such as social network size?
Yeah, I think when we interpret studies like this, it's really important to operationalize what is it actually saying. So their definition was less than two people. But again, we don't know what what that actually means. What's the quality of that? Is it a close family member? Does that social support, if it's going to be things like bladder and bowel management, are they comfortable doing that? So social networks itself don't necessarily get at those pieces of it. I think anytime you measure something, you're never going to get a perfect response to things. And as an epidemiologist, sometimes I think there was a really good quote I remember listening by it was a banker, and she said, "My job is not to solve uncertainty, it's to understand it." And I use that framework sometimes when I go through the literature to kind of say, you're never going to answer all of the questions, but I think it's important to think a little bit deeper with these questions, and try to conceptualize what they mean and what they don't mean.
Absolutely. And SEQUINS audience, you heard it here. The banking industry imparting wisdom to us.
Yes.
Nneka, what are your thoughts?
Well, one of the most important things that I look for when a person is transitioning from acute care to post-acute rehabilitation is their family members and their caregivers. And when I come into a room and do a consult on acute care, I shake everybody's hand. And I mean down to the baby that's sitting right there in the room. I look at the baby and greet the baby because this group of people are going to be the key to how successful the intervention of stroke recovery is. Who's going to get this person to their appointments? Who's going to help them with transfers from the bed to the chair? Who's going to help them in and out of the car? What is that going to look like from a sense of community? And if I don't see them there the first day, when I'm there for my first consult, I come back the next day and the next day to see if there's any additions or subtractions from the room, because that's important. That's what the concept of the study is as well. It's like, who is going to be there when things get difficult? And what is that going to look like for this stroke survivor and their family? And I can tell you, it's very difficult for it to be one person in that room. And sometimes when it's one person and they realize what's going to be required of them is when their concerns mount and the support drops.
Yeah, yeah. Well said. Well said. Thank you so much. So now Kent is going to take us home. We're going to look at this paper on sex differences in prognostic markers, exploring the outcome variability after thrombectomy in large vessel occlusion strokes. This was published in Clin Med in 2025. And so thank you, Dr. Simmons.
Yeah. So this was an interesting study out of Germany. So prior research has shown that women may be less likely to achieve functional independence scores compared to men at 90 days, following mechanical thrombectomy for large vessel occlusion. Their objective was to look at if there was differences in biological prognostic markers for outcomes following mechanical thrombectomy between men and women. This was a single center retrospective study. Data was collected between 2014 and 2020. They had a total of 183 patients, and so they had to have a CT confirmed, anterior circulation, large vessel occlusion, and symptom onset within 6 hours, and then following that with mechanical thrombectomy. They had multiple exposures, so they were looking at sex differences. Other differences were age, aspects, score, core lesion volume, penumbra volume, if there was the collateral status, as well as time to reperfusion. The outcome that they were using was the modified Rankin at discharge and at 90 days. And so they looked at outcomes in two different ways. So they did a binary outcome using modified ranking, looking at a favorable versus unfavorable score. And this was following what prior studies of literature had done. So favorable MRS of 0 to 2, and unfavorable greater than 3. And they also looked at an ordinal measure. So the full range of modified ranking, which can range from 0 to 6. So just briefly, 0 to 1 is kind of no symptoms of disability. 2 to 3 is kind of moderate disability, some assistance. 5 to 6 is moderate to severe, near constant care. And then 6 is death. And then they were using a multivariable ordinal logistic regression, and they did stratify by sex differences. So in their binary analysis, which had followed some of the previous literature, they didn't see a difference between males and females, between getting a favorable versus unfavorable outcome at 90 days. But when they looked at the full spectrum, they did see a difference. And so when you look at the granularity of how patients are doing, that's where they found an odds ratio of 0.43, depending upon which group they were in from the 0 to 6 of that modified Rankin score. And then they also found differences in prognostic biomarkers associated with favorable recovery. So for males, core lesion volume was associated with improved odds, and for females, it was their initial NIHSS score, that TK score, and the penumbra volume. Some of the limitations of this study, it's a single center, relatively smaller sample size for this type of analysis at 183 patients. And especially for a smaller sample size to stratify by sex and to look at multiple potential exposure variables is always something that should have a little question in your mind. And then modified Rankin, again, it matters. It's good that they just granular score, but modified Rankin is not the end all be all of function. Um, and then, yeah, it can lack precision, and to sort of get some of those finer differences in granularity of recovery. It's more of a global measure of function. And some of the conclusions were that there were some disparities following mechanical thrombectomy, but those are only discovered when you look at the full range of modified Rankin, not in a binary favorable versus unfavorable way. And then the underlying sort of prognostic architecture of what factors are associated with favorable outcomes also sort of changes. That has implications for deciding, the risks and benefits of a procedure moving forward, and there might be sex differences there. And I think it highlights the importance of, looking at these sex-specific differences, as well as clinical indications, prior to doing these cardiovascular interventions.
No, thank you. And I know you wanted to just also go over these data.
Yeah, so to sort of cover this, and so this is sort of showing, so on the left, you have the favorable outcome at discharge. And so um, there you can see that there's a sex difference in penumbra volume between males and females. And then on the right, they were looking at 90 days. And so there you can see there's less of a difference across the board.
Right. Right. No, no, thank you for this. And of course, Kent, studies of this nature always beg the question, are these results representative of underlying physiologic sex-specific differences in response and recovery following, in this case, mechanical thrombectomy?
I think it's challenge. I think it's always tempting to say yes because yes is the exciting answer in these elements, but I think it's always it will serve you well, I think, sometimes to pause and to think it through. And so, especially with a sample size of 183, sometimes you can use things like testing interactions prior to stratification, and you can always get caught up in the statistical noise and never find a difference. And so it's there's an art in interpreting these results as well. But I think it's difficult to get at the biological mechanisms because they only adjusted for sort of age predominantly. We didn't have a great sense of other comorbidities, what medications were they using, and this is a rehab discussion. We didn't have any idea for what kind of rehab these patients went after. I don't know about the German context, but I do know within the US context, there's a difference in terms of a pretty strong difference of sex difference of likelihood of patients going to sort of more intensive inpatient rehab compared to skilled nursing facilities. So if that translates to the German context as well, then I think getting into the biological mechanisms is weeding a little bit into the unknown fog from things like this. But it definitely gives a good idea for outlining future research for where studies might begin to kind of look to see if there's some consistency across the board.
I love the way you weaved that. That was excellent. Very well balanced. No, love that. And so I think when you were concluding and talking about the implications, Kent, you said it's important, and rightly so, to do sex-specific analysis. But should they always be performed as an a priori analysis, or should more advanced statistical tests, such as testing for interaction, be performed prior to stratifying?
I think it's good to at least, even if it's not statistically significant, to test the interaction. So to go into a little bit, an interaction is basically saying that we think that there's a biological difference um, in the treatment effect potentially that leads to these differences in outcomes. And so that's what the interaction will test. And sometimes if I teach about interactions as well, you can have chocolate, most people like it, right? Pizza, most people like it, but chocolate on pizza may not be good, right? So these variables themselves are not, sometimes they interact with each other. And so you cannot always, and most of our statistical analyses in these multivariate analysis basically will take one variable at a time. And so the interaction will test, is this difference consistent across each subgroup and strata? So that's what it's testing. And so here it was a priori what they were looking at. But I still would have liked to have at least seen an interaction test, even if they proceeded to do the analysis without it. And I think it also gets challenging in terms of, we want to identify these sex differences. We see they're very real. But there's a number of other things. So women with stroke tend to be older, tend to be more frail. There can be differences in access to rehab. And so leading too deep into the biological plausibility, if we're unable to adjust for that, and especially in a group of 183, I think it's challenging to do so. But I think this is a great way in terms of at least opening the question for future research to kind of look to see, is there consistency across these boards? And can we explain that by some kind of physiological mechanism?
Yeah, and I fully endorse everything you just said. I think even as an editor, that's definitely something, or a reviewer I would ask for to be done, to see what if any in terms of interaction. So no, well said, and thank you so much. Nneka, any thoughts on this one?
I'm very thankful that I recruited Kent to join the lab. That's pretty much my thought. It's important to have an epidemiological lens on this. And I think that when it comes to sex differences, we cannot forget that women are primarily caregivers too. So if a woman has a stroke, who's caring for the woman?
It's true. It's true. It's true. No, well said. And couldn't be a better way for us to conclude the this wonderful discussion that we've had. I just want to say a big thank you to Dr. Ifejika and Dr. Simmons for allowing us to benefit from their knowledge, their insights, their experiences. Just fantastic. And I hope that viewers and the audience see it as I do, that this is a step forward for us to better understand the stroke rehab world, but also to identify ways for us to move forward and educate policymakers about avenues for us to do better and more research in this area. I would like to remind all of you that the Society of Equity Neuroscience, SEQUINS, has a conference every year. Next year, we're going to be doing it with the American Neurological Association in Chicago in September. We also have a scientific journal. Please feel free to submit your work to us. Feel free to be a reviewer for us. We also have a monthly podcast in which we interview experts in brain health disparities and brain health equity. And then finally, we have experts just like Dr. Simmons and Dr. Ifejika provide us with academic discourse such as this one, so we can all be enlightened about the avenues we can seek to try and bridge these very important disparities. So again, I want to thank Dr. Simmons and Dr. Ifejika, and I want to thank the audience. Thank you so much for a wonderful session.
Thank you.
Thank you, everyone.